There is such a notion, secondary upper extremity lymphedema. This problem is connected with the consequences of the cancer-related breast removal and extended axillary lymphadenectomy. There is a special algorithm of not only diagnostics but also surgical treatment and other types of therapy as well, i.e. chemotherapy, radiation therapy. Oncologists have perfected this algorithm, which is very nice, but in some cases, upper extremity edema develops after the surgery, and namely, breast removal with the axillary lymphadenectomy. Figures differ, but it takes place in 40 to 70% of the cases. The cause is impaired lymph drainage. The removal of axillary lymph nodes is a very important component of the surgical treatment of tumoral relapses. The emergence of metastasis is very negative for patients. That is why these regional lymph nodes are removed urgently. Radical mastectomy nowadays remains the primary surgical breast cancer treatment method. It is applied in both complex and combination approaches with other treatment methods such as surgical chemotherapy, therapeutic chemotherapy, radiation therapy, and mastectomy. Radical mastectomy, and radical is the key word in this case, implies the removal of a breast together with the adipose tissue and regional lymph nodes. Regional lymph nodes comprise interpectoral and axillary, intraclavicular and infrascapular lymph nodes. The removal of these lymph nodes causes upper extremity edemas in 60 to 70% of the patients at an early stage during the postoperative period or in 5 to 10 years after the procedure, as lymph drainage from the upper extremity, more specifically from the medial surface of the arm, is interrupted. Only lymph drainage from the outer surface of the arm is preserved, and lymph goes to the delta pectoral lymph node and subsequently to the supraclavicular lymph node. This path can compensate for the state of upper extremity for a long period of time. However, overall practical experience shows that this path is insufficient, so edema develops in some time. Several years ago, Dr. Beitinger proposed to carry out experiments with contrast agents visible in the infrared range. One of these agents, indocyanine green, is widely used. The other, methylene blue, is manufactured in Russia. We found out that the waves of a specific length could make this agent, methylene blue, fluoresce. However, we do not set these two agents against each other. We use both of them. Thus, we developed a technology that implied using methylene blue to verify lymph drainage from the breast, including signal or sentinel lymph nodes, as they are called nowadays. We performed an experiment and were very happy to see that the fluorescence produced by methylene blue was even more vivid than that of indocyanine green. We were very thrilled. We have designed a device which uses 3 cameras working in the visible light range and in 2 intervals of the infrared range, corresponding to indocyanine green and methylene blue frequencies. All 3 images are combined in real time and synchronized so that the surgeon can see the lymph nodes and lymphatic ducts in the resulting picture. This technology is well developed at the moment. We have performed experiments, and now we have to adapt this technology to patients. That's what we are doing at the moment. This work is extremely important, as we hope to initiate clinical trials for this method.